Hello everyone. Good morning, good afternoon, wherever you are. Today we're going to be presenting on emergency nursing regarding its principles and management in emergency department. So let's begin. So today, by the end of this presentation, you'll be learning different triage systems used in the US Emergency Department, both ESI and CTAS, and also apply ABCDE framework to perform systematic primary survey, identify key nursing interventions for heat, cold injuries, poisoning, opioid overdose, recognize and respond to cardiac emergencies, including ventricular fibrillation, PEA, Asystole, and explain the role of emergency medications, epinephrine, lidocaine, and many more. Along with that, you'll also be able to identify signs of violence, psychiatric emergencies, such as human trafficking in the ED. So, what do you mean by triage? So, how do we prioritize the patient's conditions in emergency? So, there is a triage system based on Emergency Severity Index, which is commonly practiced in USA, and there is CTA's Canadian triage and equity scale commonly used in Canada. So, the level 1 is resuscitation, which needs immediate care and it is life threatening. It needs to be provided within 15 minutes, um, before 15 minutes. And the level 2 is emergent, treat within 15 minutes. Level 3 is urgent, and we have to treat urgent patient within 30 minutes of time. On top of that, for the level 4, it is less urgent, so we can wait 1 hour. The level 5 is non-urgent, so it's just a simple evaluation. So for the Canadian triage and equity scale, level 1 is resuscitation, just like ESI, and emergent within 15 minutes, urgent within 30 minutes. Level 4 is less urgent within 60 minutes, and level 5 is non-urgent. We just provide simple care to the patient, and patient can wait more than 60 minutes. All right. If you have any questions, you can comment. So let's move to slide 4. So what are primary survey and what is ABCDE framework? How do you assess the patient? So this framework is airway, breathing, circulation, disability, and exposure. First off, you will assess the patency, such as nasal patency, if nasal patency is maintained or blocked, and also assess cervical spine. We always have to protect the cervical spine during the trauma or injury, even when patient is conscious and unconscious. And there are different maneuvers such as head tilt, chin lift, or jaw thrust. We won't be discussing here. Um, the second is breathing. So we auscultate breath sounds with the state. You'll be assessing bronchosvascular sounds, vesicular sounds, and also assess respiratory rate and depth along with O2 sats. For the circulation, we'll be monitoring heart rate with the pulse ox and with the BP instrument. We'll measure BP, blood pressure, and also the peripheral pulses such as dorsalis pedis and posterior tibial, and control bleeding. For to control bleeding, we there's a different protocol, but we also maintain IV access in the emergency to improve the circulation, and also perform CPR if needed. And we all of us have to have a BLS for a healthcare worker from American Heart Association, certification from AHA. So for the disability, If the patient is unconscious, we use Glasgow Coma Scale to assess the consciousness or neurological assessment. If the score is less than 8, it is severe. And for the exposure, remove all the clothing, assess for life-threatening injuries uh, on all the sides of the bodies, lateral, left lateral, right lateral, on the back, and all the extremities, preserve privacy as well as warmth. All right, let's move to next slide. So let's go deeper into airway. For a patient who is awake and responsive, the airway is presumed open, right? If the patient is unresponsive with no suspected trauma, we use the head tilt chin lift maneuver. This lifts the tongue off the laryngopharynx and opens the airway. If the trauma is suspected, we instead use the modified jaw thrust, which maintains the cervical spine alignment while opening the airway. And nursing action include inspecting for blood, broken teeth, vomit, or any vomitous foreign bodies in the airway, um, in the mouth, and we suction as needed. Airway adjuncts include oropharyngeal or nasopharyngeal airways, a bag valve mask delivering 100% oxygen. We can use ambo bag, right? And a non-rebreather NRB mask for certain conditions such as COPD and for spontaneous breathers. And one critical reminder is hypoxia can cause irreversible brain injury or death within just 3 to 5 minutes. So airway is the first prioritization um, in the emergency setting. Moving to breathing, in the framework ABCDE, breathing is the second framework, and C is the third framework. We're going to be discussing breathing and circulation together. So, breathing assessment, we assess the lung sounds. We also observe the chest expansion, the rise and fall of the chest, and the respiratory effort, whether it's effortless or it's more vigorous. If the patient is comfortable or patient is at severe distress. We also assess rate and depth of respirations, chest trauma, tracheal position. You have to also assess if the trachea is in centrally placed or if it's deviated to either side. Measure O2 saturation. If the patient is not breathing or breathing inadequately, we supply nasal cannula, oxygen through nasal cannula, and then inform the provider as well as upgrade to the other oxygen delivery devices based on the prescription or based on the provider's order. Okay, and then until ambu bag or ambu bag valve mask is obtained. So for the C, circulation actions, we have to restore the circulation by performing CPR when CPR is needed, assess external bleeding. We can apply direct pressure, such as applying tourniquet proximal to the site of injury or bleeding to prevent the blood loss, or in case of hemorrhage, or in case of bleeding open wound. And we also perform wound packing and hemostatic dressings, open large bore IV cannula in the antecubital fossa, and provide lactated ringers RL solution or 0.9% isotonic NaCl. To alleviate the shock, we administer oxygen, provide IV fluids, blood products, monitor vitals, also monitor I's and O's, urine input and output, reassurance, and anxiety support. For disability, so For the disability and exposure, there's ABPU mnemonic: A for alert, B for responsive to voice, P for responsive to pain, U unresponsive. And for GCS, Glasgow Coma Scale, eye opening 1 to 4, verbal response 1 to 5, motor response 1 to 6, total score is 3 to 15. So score less than 8 is severe brain injury. Let's move to next slide. Now we're going to be discussing about heat and cold related injuries, hypothermia, heat stroke, and frostbite. So for hypothermia, environmental emergencies are an important component of emergency nursing. Hypothermia occurs when core body temperature drops to 35 degrees Celsius or below. Signs include shivering, impaired judgment, slurred speech, or drowsiness. And nursing actions are assessing ABCDs, always assessing ABCDs first. Remove wet clothing, apply warm blankets, increase room temperature, use heat lamp, infuse warmed IV fluids, and monitor for hypoxemia, acidosis, as well as coma. We have to send the AVG, arterial blood gas analysis uh, for that. And the heat stroke is opposite, quite extreme. Core temperature exceeds more than 40 degrees Celsius or 104 degrees Fahrenheit. So findings include altered mental status, abnormal electrolytes, and either absent or excessive perspiration. So we rapidly cool the patient with wet towels in case of heat stroke, ice packs. You can provide cooling blankets, administer oxygen, and run a large bore IV with normal saline infusion. For the first bite, severity ranges from first degree superficial injury to fourth degree gangrene with bone or tendon necrosis. So the treatment depends on the degree. We rewarm affected areas in a warm, not hot water bath. Avoid rubbing the injured areas. Never ever rub the injured area. Administer analgesics and tetanus toxoid vaccine, and closely monitor the circulation. So next is poisoning assessment and the nursing management for the poisoning. When poisoning is exposed to patient, whether medication, it could be illicit drug or environmental substance, and it constitutes a true medical emergency requiring a rapid, fast intervention. Those most at risk include children under 5 years old due to accidental ingestion, such as kerosene ingestion, and individuals with substance use disorder. Expected findings may vary by toxic agent, so obtaining a thorough patient history is very crucial. We also monitor blood toxin screen, electrolytes, ABCs, glucose, coagulation profile, kidney and liver profile. Nursing management includes providing respiratory support, contacting poison control, administering activated charcoal orally or via NG tube, and performing gastric lavage if the patient presents with 1 hour of ingestion. An important point here is syrup of ipecac is no longer recommended. So we administer appropriate antidotes, monitor blood pressure and cardiac rhythm via ECG, restore fluids through IV therapy, and administer diazepam based on the order when seizure occurs. For opioid poisoning, opioid overdose is a public health crisis all over the globe. Approximately 80,000 Americans died from opioid overdose in 2022 alone, making it the most leading cause of injury-related death in the United States, driven primarily by synthetic opiates like fentanyl. Expected clinical findings include pinpoint pupil, uh, also called meiosis, decreased blood pressure, respiratory depression, um, seizures, decreased level of consciousness, hypoxia. If the patient is unresponsive with no pulse, immediately initiate CPR and attach AED. And key nursing actions are maintaining a patent airway, providing rescue breathing, and administering naloxone, opioid antagonist as a primary reversal agent. But do not administer syrup of ipecac, and know that lidocaine is not indicated in opioid overdose either. So, after stabilization, initiate a referral for substance use treatment. And importantly, first responders are now equipped with naloxone for emergent administration in the community. For the bites and psychiatric emergencies, this slide covers several distinct emergency situations. For snake bites, we assess tissue edema every 15 to 30 minutes, which is very crucial, and monitor limb circumference and administer opioid analgesics for the pain. Antivenom is most effective within 4 to 12 hours of the bite. Critically, ice, tourniquets, heparin, and corticosteroids are contraindicated in the first 6 to 8 hours. For animal bites, we cleanse the wound thoroughly with soap and warm water for 5 to 10 minutes and apply antibiotics, ointment, and a clean dressing. And also administer TT, tetanus vaccine if indicated. Rabies immunization is given on days 3, 7, and 14 post exposure if needed. Deep puncture wounds require antibiotic therapy. Um, for psychiatric emergencies, which may present with mood changes, anxiety, or decreased self-esteem, we remain calm and supportive in the emergency department and avoid restraints when possible, administer medications as ordered, and refer for crisis interventions. Um, Finally, regarding violence and human trafficking, red flags include unexplained bruising. Always look for bruises, burns, or lacerations, even it's minor, fractures, healing in various stages in the various parts of the body, and a frightened or agitated appearance. Always ask questions in private, preserve evidence, be supportive, and always implement the therapeutic communication with the patient and report to the facility as per facility protocol. So for cardiac emergencies are always life threatening and require immediate recognition and response. Ventricular fibrillation is a chaotic ventricular electrical activity resulting in loss of consciousness and apnea. So management follows AHA ACLS protocol. Begin BLS, deliver defibrillation, perform high quality CPR for 2 minutes, administer epinephrine, establish an advanced airway, and give amiodarone or lidocaine if there is no response. Pulseless ventricular tachycardia or PVD involves ectopic firing between 140 and 180 beats per minute, leading to unconsciousness and deterioration into ventricular fibrillation. So the management protocol is quite similar to ventricular fibrillation. Um, but for the PEA, pulseless electrical activity, or is a situation where there is organized electrical activity on the monitor but no cardiac contraction. So we perform CPR and have the IV access or intraosseous access, administer epinephrine 1 milligram IV every 3 to 5 minutes, or also inform the provider and place an advanced airway or treat reversible causes, the 5H and 5Ts, which we will cover next. Asystole is the complete absence of all electrical activity, full cardiac arrest. So management meters PEA. If asystole persists without response, the ER team may consider ceasing resuscitation efforts. Let's move to the next slide. So what are 5HTs and 5Ts for the post-resuscitation care? When managing PA or asystole, we systematically source for reversible causes using the 5H and 5T framework. The 5H are hypovolemia, hypoxia, hydrogen ion accumulation, or we call it acidosis, hypokalemia, or could be hyperkalemia, and hypothermia. The five T's are toxins from accidental or deliberate overdose, cardiac tamponade, tension pneumothorax, and thrombosis. It could be both coronary or pulmonary. Identifying and treating these reversible causes can mean the difference between life and death. So always remember these can be reversed. It all depends on the ER team and the time. After return of the spontaneous circulation, post-resuscitation care includes monitoring oxygenation, ventilation, continuous telemetry, and AVZ monitoring, tracking urine output, as well as administering IV fluids, inotropes, or vasopressors as ordered or prescribed, and monitoring for temperature, the vitals, managing seizures, also checking blood glucose level, electrolytes, and completing the diagnostic for the test as well. All right, let's move to the next slide. So, what medications are commonly used in emergency conditions that we discussed in the previous slides? So the three core emergency medications are essential in this chapter. Epinephrine act as both alpha-1 and beta-1 receptors. As an alpha-1 agent, it causes vasoconstriction, elevates blood pressure, manages bleeding, and treats AV block. But it can cause hypertensive crisis. So as a beta-1 agent, it is used in AV block and cardiac arrest, but can cause dysrhythmias. Be mindful of dysrhythmia or tachycardia, increase oxygen demand leading to angina again. And nursing action include continuous cardiac monitoring and reporting any abnormal or deranged vital signs. Lidocaine is used for ventricular dysrhythmias, including ventricular tachycardia and ventricular fibrillation. Adverse effects include confusion, bradycardia, heart block, hypotension, and it's hypotension, and in severe cases cardiac arrest. We basically monitor electrolytes and watch closely for toxicity. Amiodarone is used for VF or pulseless VT, ventricular tachycardia, when defibrillation alone fails. So the adverse effects include bradycardia, hypotension, ARDS, pulmonary toxicity. We monitor for signs for pulmonary compromise, such as crackles, so always assess the lungs, and hypoxia or dyspnea. So track blood pressure as well as other vital signs very closely. So next we will be discussing about NCLEX-style questions. Let's test our understanding with three NCLEX-style questions. Question 1. A nurse encounters an unresponsive client who was not in a trauma. Which technique should the nurse use to open the airway? The answer is head, tilt, chin lift. This is used when there is no suspected cervical trauma. But modified jaw thrust is reserved for trauma patient. So always remember, modified jaw thrust is for trauma patient. And for the non-trauma patient, the answer is always head, tilt, chin lift maneuver. Question 2. An ED nurse cares for a client exposed to freezing temperatures for hours. The client is alert and talking. Which actions should the nurse take? Select all that apply. Take your time. Select all that apply. The correct answers are remove wet clothing, apply warm blankets, infuse warm IV fluids, administering acetaminophen, and simply maintaining the room temperature are not appropriate interventions. So always remove wet clothing, apply warm blankets, and infuse warm IV fluids. Question 3. A client with suspected opiate poisoning becomes unresponsive with absent respirations and no pulse. What actions should the nurse take? So the client with suspected opiate poisoning becomes unresponsive with absent respiration and no pulse. Could be opioid overdose, right? And then Select all that apply. The correct answers are administer naloxone, begin CPR, and obtain an AED. We don't provide any lidocaine, neither any syrup or ibuprofen. All right, these are my references. Thank you so much. If you have any questions, if you'd like to me to make any other presentation, any other topic from Med-Surg, please let me know in the comment, and also provide feedback for this slide and this content. Constructive criticisms are always welcome, and I hope you enjoy and learn from this presentation.